Doctor, how long the session might go on? Like, how many minutes? You're on mute.
By 1 hour, I think I will be done.
Okay. After that, there will be a Q&A session. Doctor, how long the session might go on? Like, how many minutes?
Uh,
Vijay?
Gana, we are on live on YouTube. So,
Oh, okay.
Yeah.
Sure, Vijay. I'm sorry.
Okay, Gana, I'll let in everyone and I'll go for mute. See you at the
Sure,
end.
Vijay.
Thank
Sure.
you.
Thank you. Vijay, can you please give me a moment? Vijay, can you see Dr. Raisa? Yes. Hey, Hall. We'll start the session at 6:05. We are expecting few more to join. Thank you. Good evening to each and everyone. I am thrilled to welcome you all for today's informative webinar on gestational hypertension and pre-eclampsia in pregnancy. I am Gagana Ballari, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for today, Dr. Raisa Samuel. Dr. Raisa Samuel, an accomplished medical professional, holds an MBBS, DGO, and MS in obstetrics and gynecology from the prestigious college CMC Vellore. She has further specialized with a postgraduate diploma in family medicine from the same institution, reinforcing a commitment to providing holistic and comprehensive women's healthcare. Dr. Reisa's expertise in obstetrics and gynecology is well supported by her significant contributions to medical research. Dr. Reisa's dedication to both clinical practice and academic research underscores her role as a key figure in advancing obstetrics and gynecological care in India. Thank you. Over to you, Dr. Raisa.
Good evening. I will be starting my presentation now. Today's topic is gestational hypertension and pre-eclampsia. Okay, pre-eclampsia, the background of these patients are that these are the patients who have risk factors for having pre-eclampsia. Those are nulliparity, multifetal gestation, pre-eclampsia in previous pregnancy, chronic hypertensives, those who have pre-gestational diabetes, gestational diabetes, thrombophilia, SLE, pre-pregnancy if their BMI is more than 30, if they have APLA syndrome, that is antiphospholipid antibody syndrome, maternal age more than 35 years or older, if they are a known case of any kidney disease, if they have underwent assisted reproductive technology, or if they have obstructive sleep apnea. All these patients are at risk of having preeclampsia in pregnancy. So what is the definition of each hypertensive disorders in pregnancy, and how do we diagnose them, and what is the management? Those will be dealt in this class. So gestational hypertension, which is the most commonly seen hypertensive disorder in pregnancy, it is defined as a systolic blood pressure of 140 mm of Hg or more, or diastolic blood pressure of 90 mm of Hg or more in 2 occasions, at least 4 hours apart, after 20 weeks of gestation in a woman who with a previously normal blood pressure. They are defined as gestational hypertension. In case of severe gestational hypertension, the systolic blood pressure is more than 160 and diastolic is more than 110. And we do not wait for 4 hours because we need to treat them immediately. So immediately we have to start an antihypertensive therapy. So we will confirm them within a short interval. Maybe within 5 minutes or 10 minutes, we might repeat the blood pressure and see. And if it is persistently more than 160, 110, then we will term them as severe gestational hypertension. Now, what is preeclampsia? It can be with or without severe features. Preeclampsia is defined as a disorder of pregnancy which is associated with new onset hypertension. That is, previously the lady did not have any hypertension, normal blood pressures, which occurs most often after 20 weeks of gestation and frequently near term. And this blood pressure also, if they have blood pressures come back to normal after 12 weeks of delivery. They are termed as preeclampsia. Now, how do we diagnose preeclampsia? The blood pressure criteria is systolic blood pressure of 140 or diastolic blood pressure of 90 or more in 2 occasions, which is 4 hours apart after 20 weeks with a previously normal blood pressure. We term them as preeclampsia. And in severe preeclampsia, that is, the blood pressure will be more than 160 by 110. And in this, as I said before, that we will monitor the blood pressure in a short interval. Now, the other things associated with preeclampsia is proteinuria, which is 300 mg or more per 24-hour urine collection, or this amount extrapolated from a timed collection. That is, you have to start from 8 a.m. to next day 8 a.m. Then only, and if send the urine, and if the urine protein comes back as more than 300, we term this as proteinuria, or the protein by creatinine ratio is more than 0.3 mg per deciliter, or if all this is not available, then a normal dipstick reading of 2 plus or more, we term them as proteinuria. So in the absence of proteinuria, if they have other features, these are the features which shows the severity. New onset hypertension with the new onset of any of the following features, then again we term them as severe features of preeclampsia. So thrombocytopenia, that is platelet count less than 1 lakh, renal insufficiency where the serum creatinine level is more than 1.1, or if there is a doubling of the serum creatinine concentration in the absence of any other renal disease. Impaired liver function, that is elevated liver enzymes, SGOT, SGPT will be elevated. If there is pulmonary edema, if there is new onset headache, which is unresponsive to medication and not accounted for by alternative diagnosis or visual symptoms. If they don't have any visual inability and if they have a new onset headache, which by giving like a painkiller, if the headache is not subsiding like Crocin or something, then we consider this as a severe feature. Now, preeclampsia with severe features, again, the systolic blood pressure should be 160 or more, diastolic of 110 or more, at least 4 hours apart, thrombocytopenia less than 1 lakh, impaired liver function test, as I have told that the liver enzymes will be elevated, or there is a severe persistent right upper quadrant or epigastric pain, which is unresponsive to medications. If there is renal insufficiency, that is the creatinine level is more than 1.1, and in the absence of other renal diseases, pulmonary edema, new onset headache. All these are severe features of preeclampsia with visual disturbances also. So these are the symptoms that we most commonly ask a patient with hypertension to rule out if they're in impending eclampsia, or to classify them as severe features of preeclampsia. Now, what is HELP syndrome? HELP syndrome is hemolysis, elevated liver enzymes, and low platelet count syndrome. This is the diagnostic criteria is if the LDH, that is, how do we know there is hemolysis? The LDH level will be more than 600. If the SGOT, SGPT is twice the upper limit of normal, if the platelet is less than 1 lakh. So you can classify them as HELP syndrome. Now, what is eclampsia? Eclampsia is the convulsive manifestation of hypertensive disorders of pregnancy and is among the more severe manifestations of the disease. Eclampsia is defined by new onset tonic-clonic, focal or multifocal seizures in the absence of other causative conditions such as epilepsy, cerebral arterial ischemia and infarction, intracranial hemorrhage, or any drug use. Some of these alternative diagnoses may be more likely in cases which new onset seizures occurs after 48 to 72 hours postpartum, or when the seizures occur during administration of magnesium sulfate. So if you rule out previous history of eclampsia, previous history of epilepsy and other neurological condition, and if they have a new onset eclampsia during pregnancy, then most commonly we diagnose them as eclampsia. Now, what are the pathophysiology of this preeclampsia and the spectrum of diseases associated with preeclampsia? Vascular changes, hematological changes occurs, hepatic changes, renal changes, and fetal, ultimately leading to fetal consequences. So I'm not going into the details of the pathophysiology. I'll be more dealing with the diagnosis and management. So clinically, what are the clinical considerations and recommendations? Are there any screening methods that are useful to identify women at risk of developing hypertensive disorders in pregnancy? So if a woman come to you in first trimester, are there any screening methods? That mostly this hypertension occurs in the second or third trimester. So how do we screen these? So there are several studies which have evaluated biochemical markers and a combination of biochemical and biophysical markers to predict preeclampsia in first and second trimester. But their sensitivity and specificity for prediction of early onset preeclampsia using in first trimester and second trimester biophysical and biochemical parameters are better than for late onset preeclampsia. So late one, it's difficult to diagnose, but if for an early onset preeclampsia, these markers are found to be useful. So in first trimester of pregnancy, it has been reported that a combination of maternal serum concentration of PIGF, which is usually done along with the down screening, that is the first trimester screening. And when during the first trimester screening ultrasound, if you look for the uterine artery pulsatility index, and there are other maternal parameters also, like in the first trimester screening, if there is more of the PIGF and other factors, then there is 93.1% of patients who would develop preeclampsia requiring delivery before 34 weeks of gestation. This is what the studies have found. Now, are there any prevention strategies for reducing risk of hypertensive disorders of pregnancy? So to date, there is no intervention that has proved to be effective at eliminating the risk of preeclampsia. But however, there are some studies which have done nutritional interventions. There is use of vitamin C, vitamin E, fish oil, garlic supplementation, vitamin D, folic acid, sodium restriction. All these have been studied for reducing the risk of preeclampsia, but nothing is found to be, there is evidence is insufficient for all these methods. Again, there is a meta-analysis of 13 trials which reported a significant reduction in preeclampsia with calcium supplementation, with the greatest effect among women with low baseline calcium intake. So women who tend to take less calcium, normally in pregnancy we supplement them with calcium, but if you are thinking of a risk of preeclampsia, then you can substitute them with 1000 mg of calcium. So one tablet usually contains 500. So by giving them 2 tablets of calcium, you can prevent. There are studies which have found that you can prevent the risk of preeclampsia. Now, aspirin is another drug which is found that investigators have found that an imbalance in prostacyclin and thromboxane A2 metabolism was involved in the pathogenesis of preeclampsia, leading to the initial studies of aspirin for preeclampsia prevention because of its preferential inhibition of thromboxane A2 at lower doses. So there are recent meta-analysis aggregate the data from 45 randomized trials. Only a modest reduction in preeclampsia was noted when low dose aspirin was started, and this should be started before 16 weeks of gestation, is found to reduce significantly severe preeclampsia and fetal growth restriction. So there is no point in starting low dose after 16 weeks. There is always, you should start before 16 weeks of gestation. So in which patients do we start aspirin? So we have categorized the level of risk into high, moderate, and low. So the high risk patients are history of preeclampsia. That is, in the previous pregnancy, they had preeclampsia. And especially if they ever had a adverse outcome like abruption, IUD, if they had eclampsia, seizures with or preterm delivery because of preeclampsia, severe preeclampsia, or if they had HELP syndrome, all these are adverse outcomes of preeclampsia. If they have a history of preeclampsia and these are adverse outcome in previous pregnancy, those patients we will start definitely. Multifetal gestation in chronic hypertensives, in type 1 and type 2 type 2 diabetes, in renal diseases, or in autoimmune diseases like SLE or APLA syndrome. So all these patients, we recommend low dose aspirin if the patient has one or more of these high risk factors. Moderate risk are nulliparity, obesity, that is BMI more than 30, family history of preeclampsia in mother or sister, in socio-demographic characteristics like African American race or in low SES, women who are 35 years or older, if they have a personal history of low birth weight or SGA babies in previous pregnancy with a bad outcome, or if there is a more than 10-year pregnancy interval, if they have planned this pregnancy after 10 years, these patients are all considered to be moderate risk. So these patients, again, you consider low dose of aspirin if the patient has more than one of these moderate risk factors. So two or more of these risk factors, if they have, still we will start them on low dose aspirin. If Low risk are previous uncomplicated full-term delivery. In these patients, we do not recommend aspirin. So what is the optimal treatment for gestational hypertension or preeclampsia? So as we all know that gestational hypertension or preeclampsia, most commonly they will present in third trimester, and we have to take the decision whether you have to deliver or whether you can give them expectant management. That is the most challenging question that always comes, and the decision has to be made by the obstetrician. So there is a comprehensive clinical, maternal, and fetal evaluation that is done in these patients, because we have to balance between the maternal and the fetal risk. So initial evaluation of the mother is by complete blood count with platelet estimate. That is, you do a CBC with platelets, the creatinine, LDH, SGOT, SGPT, proteinuria is seen. So these are the essential investigations that should be done on a patient who comes with you with high blood pressure. Initial evaluation of the fetus along with the mother. Fetus also has to be evaluated. Ultrasound is done for the estimated fetal weight and amniotic fluid index. If you have a center which can give you the Doppler, then Doppler studies are also done. Then fetal antepartum testing, that is the fetal trace is a cardiotocogram, or if there is NST available, you can get a fetal antepartum testing done. So the decision to deliver must balance between the maternal and the fetal risk. Mostly if they come in preterm, so again you have to decide whether you should deliver them, because the preterm complications of the fetus is there, and by prolonging the pregnancy there could be maternal complications associated with high blood pressure. So preterm plus gestational hypertension or preeclampsia without severe features, how do? We continue on monitoring comprising the serial ultrasound to determine fetal growth, weekly antepartum testing, close monitoring of the blood pressure, weekly laboratory tests for preeclampsia. So if it's a preterm with only gestational hypertension or with preeclampsia without any severe features, we can opt for expectant management. So there is retrospective data that favors continued monitoring until delivery at 37 weeks of gestation in the absence of abnormal antepartum testing, preterm labor, premature rupture of membranes, or vaginal bleeding for neonatal benefit. So if in these patients, we can take them up to term, that is 37 weeks. The risks associated with expectant management in the late preterm period are negligible compared to the complication associated with delivery before 37 weeks of gestation. So there is this is the trial which was done for HYPETITE trial, which was done for this hypertensive patients, where women after 36 weeks of gestation were allocated to expectant management or induction of labor. The latter option was associated with significant reduction in composite of adverse maternal outcome, including new onset severe preeclampsia, HELP syndrome, eclampsia, pulmonary edema, or placental abruption. In addition, no differences in rates of neonatal complication or cesarean delivery were reported by the authors. In women with gestational hypertension without severe features, where there is progression to preeclampsia with severe features, this progression usually takes 1 to 3 weeks after diagnosis, whereas women with preeclampsia without severe features, the progression to severe preeclampsia could happen within days. So without any severe features, they progress usually 1 to 3 weeks, but with severe features, normally they will progress within few days in gestational hypertension and in severe preeclampsia. Gestational hypertension or preeclampsia without severe features at or beyond 37 weeks, delivery rather than expectant management is recommended. If a patient comes to you at 37 weeks with hypertension or with preeclampsia without any severe features, better to deliver them, because we are looking only at 37 weeks term. You can plan for delivery for these patients. Preeclampsia with severe features, what do you do for them? Preeclampsia with severe features can result in acute and long-term complication for women and for a newborn. So in these patients, normally the fetus is also affected because of severe features, because the placenta there is placental damage. Because of that, there will be IUGR, blood flow towards the fetus is less, and they might have they might end in even in IUD or intrauterine death, or they can even result in abruption. So there is significant damage to the newborn, and also there is complication of woman. So in these patients, you will maternal complications include pulmonary edema, MI, stroke, acute respiratory distress syndrome, coagulopathy, renal failure, any retinal injury. All these are complications, maternal complications. These complications are more likely to occur in the presence of pre-existent medical disorders. Like I said, if they have previous history, if they are a type 1 or type 2 diabetes, if they are a chronic hypertensive, if they have a renal disease prior to it, they have a SLE, all these previous medical disorders, these complications will are more likely to occur in these patients. So the clinical course of preeclampsia with severe features is characterized by progressive deterioration of maternal and fetal condition. Delivery is recommended at or beyond 34 weeks of gestation after you stabilize the mother, or with labor or pre-labor rupture of membranes. If the woman presents to you in labor or in PROM, delivery is recommended at or beyond 34 weeks of gestation. Delivery should not be delayed for the administration of steroids in the late preterm period. So the role of steroids is only up to 34 weeks. If they present to you beyond 34 weeks, then you need not wait for the steroids to act and delay the delivery. Now, preeclampsia with severe features at less than 34 weeks. So this is one of a challenging situation. 34, 37, we are almost clear when to deliver, how to manage the patient. But when they present less than 34 weeks, you look whether the mother is stable and the fetal condition. So if the mother is stable, that there is no deteriorating maternal condition, you rule out all the complications, that maternal complications, and you look at fetal, ultrasound is done. If there is no threat to the fetus, that is the blood flow towards the fetus is normal, there is no Doppler change, there is no IUGR, there is no decreased amniotic fluid, then you can consider expectant management. There are 2 randomized control trials of delivery versus expectant management. So expectant management is associated with higher gestational age at delivery and improved neonatal outcome. So obviously the neonatal outcome will be better with expectant management, because you're not delivering a preterm baby. If delivery is indicated at or less than 34 weeks of gestation, you have to administer corticosteroids for fetal lung maturation, and this is recommended. So normally we give betamethasone 12 mg IM, 2 doses 24 hours apart, but again depends upon whether how is the maternal condition. In case if you need to expedite the delivery, then you can even give them 12 hours apart. Conditions precluding expectant management. So in a mother, if there is uncontrolled severe range blood pressure, that is systolic blood pressure more than 160 or diastolic more than 110 or more, or 110 or more, and not responsive to antihypertensive medication, then you have to consider delivery. If there is persistent headaches refractory to treatment, epigastric pain or right upper pain unresponsive to repeat analgesics, visual disturbances, motor deficit or altered sensorium, if there is stroke, myocardial infarction, HELP syndrome, new or worsening renal dysfunction, serum creatinine that is more than 1.1 or twice the baseline, if there is pulmonary edema, eclampsia, suspected acute placental abruption or vaginal bleeding in the absence of placenta previa. All these are maternal conditions in which you will not do an expectant management. In fetus, if there is abnormal fetal testing, fetal death, fetus without expectation for survival at the time of maternal diagnosis, and example like lethal anomaly or extreme prematurity, persistent reversed and diastolic flow in the umbilical artery. As I said, these are the things that we look in the ultrasound Doppler studies. If there is any abnormal Dopplers, that is, if there is abnormal flow of the blood in the umbilical artery. So inpatient, next we will go to the inpatient versus outpatient management. Is there a role in outpatient management in PIH? So there is ambulatory management at home is an option only for women with gestational hypertension or pre-eclampsia without any severe features and requires frequent fetal and maternal evaluation. You can manage this patient on an outpatient basis, but provided they are only gestational hypertensive and preeclampsia without severe features. Hospitalization is appropriate for women with severe features and for women in whom adherence to frequent monitoring is a concern. So if the patient with gestational hypertension who are not compliant with your monitoring, that is they have to come weekly or bi-weekly, they might have to come to your outpatient, then those patients also you will advise hospitalization. Fetal, how do you monitor these patients? Fetal monitoring consists of ultrasound to determine the fetal growth. Every 3 to 4 weeks, you have to do an ultrasound to see their growth. Amniotic fluid volume, at least once weekly. Antenatal test, 1 to 2 times per week. Maternal evaluation consists of frequent evaluation for either the development of or worsening of the preeclampsia. You can ask them history of headache, any epigastric pain, any pain in the abdomen, how is your urine output, any diplopia, any difficulty in vision. All these are history you can ask the patient. Then weekly evaluation of platelet count, creatinine, and liver enzymes. Once weekly, you will assess the proteinuria. These tests should be repeated sooner if there is disease progression as a concern. Symptoms of preeclampsia with severe features are like examples: headache, visual disturbances, epigastric pain, and shortness of breath. All these are the symptoms that you will ask the patient. How do you manage intrapartum in these patients? In addition to appropriate management of the labor and delivery, the two main goals of management of women with preeclampsia during labor and delivery are prevention of seizures and control of hypertension. During labor, there is a possibility, because it's a trigger to have seizures. So your aim is to prevent the seizure and you have to control the hypertension. So for seizure prophylaxis, what is the drug that you give? Magnesium sulfate is given to prevent seizures in preeclampsia with severe features and in eclampsia. So it is found that magnesium sulfate can more than half the risk of eclampsia, reduce the risk of abruption, can reduce the risk of maternal mortality, had no difference in maternal morbidity or perinatal mortality. It caused adverse of hot flushes in a quarter of women. There is an increased rate of cesarean rate by 5%. So this was all found by the usage of magnesium sulfate. But definitely the benefit is more than the risk. So magnesium sulfate is more effective than any other drugs like phenytoin, diazepam, or nimodipine in reducing eclampsia. So the drug of choice in prevention of eclampsia in the intrapartum and postpartum period is magnesium sulfate. Benzodiazepines and phenytoin are justified only in the context of antiepileptic treatment or when the magnesium sulfate is contraindicated or unavailable. Like in cases of myasthenia gravis, hypocalcemia, moderate to severe renal failure, cardiac ischemia, heart block, or myocarditis, you might consider using these other drugs. So the dosage of magnesium sulfate, the regimen which is generally preferred is intravenous regimen, which is administration of 4 to 6 grams of loading dose over 20 to 30 minutes, followed by a maintenance dose of 1 to 2 grams per hour. So this is the most common regimen that is used. For women requiring cesarean delivery before the onset of labor, the infusion should ideally begin before surgery and should continue during the surgery as well as for 24 hours after the delivery. So that is after cesarean section. Who deliver vaginally, the infusion should continue for 24 hours after delivery. So there is no, the importance of giving magnesium sulfate is to prevent seizures. So you should not stop the magnesium sulfate immediately after delivery. You should always give 24 hours after, till 24 hours after delivery. In case of difficulty in establishing venous access, like if you are in a setup where you are not able to give it intravenously, then you can opt for the IM route. That is, magnesium sulfate can be administered by intramuscular injection. 10 grams is given initially as a loading dose, 5 grams IM in each buttocks. That is loading, followed by 5 grams every 4 hours. So here again, you will give in alternate buttocks every 4 hours, 5 grams. The medication can be mixed with 1 ml of xylocaine, 2% solution, because the IM administration is quite painful. And there is you should always use a Z technique in giving IM injection, because it's quite painful. Do not give it in the same site. So you can give it in a Z way, IM. What is the magnesium sulfate again is associated with toxicity. So these patients who are on max self infusion has to be monitored every hourly. You have to look for the urine output, patellar reflexes, and respiratory rate. All this has to be monitored every hourly to look for any signs of toxicity. So the level 4 to 7 milliequivalent per liter is the therapeutic range. If it becomes more than 7, then there is loss of patellar reflexes. If the range becomes more than 10, then they will have respiratory paralysis. If the range is more than 25, they can have cardiac arrest. So magnesium sulfate is given in a setup where you have people to monitor the patient continuously. Antihypertensives that are used in pre-eclampsia and severe pre-eclampsia. So there are drugs and thresholds for treatment. So the drugs prevent congestive heart failure, myocardial ischemia, renal injury or failure, and ischemic or hemorrhagic stroke. So our aim is to bring down the blood pressure so that you can prevent all these complications. You can use intravenous hydralazine or intravenous labetalol, or you can use oral labetalol and oral nifedipine. So these are the agents most commonly used as the antihypertensives. So there is a Cochrane systematic review which shows there is no significant differences regarding either efficacy or safety between hydralazine and labetalol, or between the hydralazine and calcium channel blockers. So they suggest that all these drugs are found to be safe in pregnancy. Parenteral antihypertensive therapy may be needed initially for the acute control of blood pressure. When they present with very high blood pressure, that is more than 160 by 110, then you might think of IV. Otherwise, you can use oral medications for expectant management. So the oral regimen that is most commonly the drug of choice that is started is labetalol. You can start them at 200 mg orally every 12 hours and increase the dose up to 800 mg orally every 8 to 12 hours as needed. The maximum total dose is 2400 mg per day. If the maximum dose is inadequate, like even after giving maximum dose of 2400, still your blood pressure is not under control, then you can add oral nifedipine, and like you can add it as 10 mg BD and further increase the dose. So the antihypertensive agents used for the urgent blood pressure control in pregnancy, labetalol is given 10 to 20 mg IV, then 20 to 80 mg every 10 to 30 minutes to a maximum dose of 300 mg, or a constant infusion of 1 to 2 mg per minute IV. So this is the intravenous intravenous method of giving labetalol. What is the adverse effect is tachycardia, but it is less common with fewer adverse effects. So, but you have to avoid in women with asthma, pre-existing myocardial disease, decompensated cardiac function, and heart block and bradycardia. The onset of action is 1 to 2 minutes. So what we say is that if you have a high blood pressure of 160 or 110, more than 160, 110, you give a 10 mg or 20 mg IV and wait for 1 to 2 minutes. You can recheck the blood pressure. Within 2 to 5 minutes, you can recheck and see if the blood pressure is falling. If it is not falling, then you can give, if you have given 20 mg, then the next dose you have to give is 40 mg. Then even with that, it is not getting controlled, then the next dose you have to give is 80 mg. So you have to keep doubling the dose. Hydralazine 5 mg IV or IM, then 5 to 10 mg IV every 20 to 40 minutes to a maximum cumulative dose of 20 mg, or constant infusion of 0.5 to 10 mg per hour you can give. Higher or frequent dose associated with maternal hypotension, headaches, and abnormal fetal heart tracings may be more common with than the other agents. So this is found to have these complications. So, but the onset of action is 10 to 20 minutes. So you have to wait for 10 to 20 minutes to wait for the action. Nifedipine immediate release. There is a nifedipine plain nifedipine and nifedipine retard. So the immediate release one, which is 10 to 20 mg orally, repeat in 20 minutes if needed, then 10 to 20 mg every 2 to 6 hours. Maximum daily dose is 180 mg. May observe reflex tachycardia and headaches. The onset of action is 5 to 10 minutes. Now, how do you monitor for disease progression? The clinical course of gestational hypertension or pre-eclampsia without severe features can evolve during labor. Hence, all women with gestational hypertension or pre-eclampsia without severe features who are in labor must be monitored for early detection of the progression to severe disease. So during labor, they are found to progress. So you have to keep a close watch on these patients who are just gestational hypertension or preeclampsia without severe features. This should include monitoring of blood pressure and symptoms during labor and delivery, as well as immediately after delivery. So these are the time when there is these are the trigger factors: labor and immediate postpartum period as the time when the blood pressure can shoot up. So magnesium sulfate therapy should be initiated if there is progression to preeclampsia with severe features. Now, what is the mode of delivery? The mode of delivery in women with gestational hypertension or preeclampsia with or without severe features should be determined by routine obstetric consideration. That is, you have to look at the obstetric indications for like whether to go for a cesarean section or for a normal vaginal delivery. You can decide gestational hypertension and preeclampsia without features can have normal induction of labor and vaginal delivery. The likelihood of cesarean delivery at less than 28 weeks is more high because the PV Bishop score will be poor. So there is 97% chance of having cesarean section at less than 28 weeks. 28 to 32 weeks is as high as 65%. For gestational hypertension or preeclampsia without severe features, vaginal delivery is preferred. There are retrospective studies of preterm women with preeclampsia with severe features concluded that induction of labor was reasonable and not harmful to low birth infants also. The decision to perform cesarean delivery should be individualized based on anticipated probability of vaginal delivery and on the nature and progression of the preeclampsia disease state. So the decision to do cesarean section is always based on each patient, whether there is a progression in a disease, whether the maternal whether there is a deterioration of the maternal condition, like if there is HELP syndrome, if her parameters are becoming deranged, if her blood pressure is not under control with antihypertensive, if she is not progressing, then you might take a decision of cesarean delivery. Again, fetal factors you look for. If there is any signs of fetal distress, if there is prolonged leaking, if there is any meconium stained liquor, if there is signs of fetal distress, again, you will take a decision of cesarean delivery. So it is individualized. There is nothing that if there is severe preeclampsia, you have to do cesarean delivery. You can give them a trial of labor vaginal delivery. Now, what
Yes,
anesthesia to
doctor.
use? Yes.
Can I take 1 minute of time of yours? Yeah, thank you. Good evening to each and everyone over here. I'm dropping a certificate and feedback link in the chat box. Kindly please fill out to get your certificates. Thank you, doctor.
Okay. Anesthesia, what anesthesia do you give for these patients? So general anesthesia is usually have more risk to pregnant women than regional anesthesia because of the risk of aspiration. Mostly these women are not fasting, so there is a risk of aspiration. There is failed intubation because of their pharyngolaryngeal edema and stroke secondary to the increased systemic and intracranial pressures during intubation and extubation. So we would avoid general anesthesia. Neuraxial anesthesia and analgesia are contraindicated in presence of coagulopathy because of the potential for hemorrhagic complications. If they have thrombocytopenia, you can have a risk of epidural hematoma. The site of where you give epidural, they could be hematoma formed in thrombocytopenia. Normal epidural or spinal anesthesia, that is regional anesthesia, is acceptable, and the risk of epidural hematoma is low in patients with a platelet count more than 70,000. So if you have a platelet of more than 70,000, you can opt for epidural or spinal anesthesia. And if the platelet is stable, there is no other acquired or congenital coagulopathy. The platelet function is normal and the patient is not on any antiplatelet or anticoagulant therapy. All these patients you can consider giving epidural or spinal anesthesia, which is regional anesthesia. So again, the effect of magnesium sulfate on muscle relaxants, it is said that it will prolong the duration of the non-depolarizing muscle relaxants. However, women with preeclampsia who require cesarean delivery should continue the magnesium sulfate infusion during delivery, because during cesarean, again, there is a chance of them having seizures. So there is no way you should stop the magnesium sulfate. This recommendation is based on the observation that magnesium sulfate half-life is 5 hours, and that discontinuation of the infusion of magnesium sulfate before cesarean delivery would only minimally reduce the magnesium concentration at the time of delivery, while possibly increasing the risk of seizure. Now, what is the treatment for eclampsia? So first, if a patient comes to you with eclampsia into your casualty, first thing you have to do is call for help. Prevention of any maternal injury. So there is a chance that they will bite their tongue. They can fall off the bed. So you might have to restrict them. You might have to keep an airway to prevent any tongue injuries or any gum injuries. Placement in lateral decubitus position, keep them in lateral position. Prevention of aspiration, so you might again have to put a airway to prevent aspiration. Administration of oxygen, monitoring vital signs including oxygen saturation. So it is like any patient who comes to you with seizures, you have to do the basic supportive measures. Most eclamptic seizures are self-limited, so they do not go into status epilepticus. They usually subside on their own. Magnesium sulfate is not necessary to arrest the seizure, but it is to prevent recurrent convulsions. During eclamptic seizures, there are usually prolonged fetal heart rate deceleration, even fetal bradycardia, and sometimes an increase in uterine contractility and baseline tone. So immediately when you look at the fetal trace, the cardiotocogram, you might see fetal heart rate deceleration, bradycardia. So you need not rush the patient for a cesarean section. You can even wait for the eclamptic seizures to subside. Look for the look for the fetal heart rate, how it is, and then take a decision. After a seizure, because of maternal hypoxia and hypercarbia, the fetal heart rate tracing may show recurrent deceleration, tachycardia, and reduced variability. So the decision again is taken after the seizure is settled, and whether there is any improvement in the fetal heart rate, then you can plan for a vaginal delivery. If not, then you might have to consider cesarean section. Only after maternal and hemodynamic stabilization should one proceed with delivery. The decision should be made only after you stabilize the mother. So you have to give priority to the mother, and maternal stabilization has to be done immediately. In the rare cases of an extremely agitated patient, IV clonazepam 1 mg or diazepam 10 mg or midazolam may be used for sedation. Women with eclampsia should be delivered in a timely fashion. Eclampsia by itself is not an indication for cesarean delivery. It has also been proposed that when the convulsions recur, so you have started the patient on magnesium sulfate, but even on magnesium sulfate, if convulsions are recurring, then you can give further 2 to 4 grams of magnesium sulfate could be administered IV over 5 minutes. Additional dose of 2 to 4 grams can be given. In cases of refractory to magnesium sulfate, that is, you were given magnesium sulfate, still they are seizuring at 20 minutes after the bolus or more than 2 recurrences, a healthcare provider should consider giving, can use sodium amobarbital, that is 250 mg IV in 3 minutes, or thiopental or phenytoin at the rate of 50 mg per minute. You have to put an endotracheal tube, and assisted ventilation in an intensive care unit are appropriate in these circumstances. This is like status epilepticus, where there is recurrence of seizures even after giving magnesium sulfate. Head imaging should be considered because most of the cases refractory to magnesium sulfate therapy may prove to have abnormal findings on the MRI or CT. Management of acute complications for preeclampsia with HELP. So HELP syndrome, women with HELP syndrome should be delivered regardless of their gestational age. Once you have diagnosed them with HELP syndrome, there is no role of expectant management. Immediate delivery has to be done. Very close monitoring is required in HELP syndrome until delivery and the postpartum period, with laboratory testing at least 12-hour interval. So you have to send all these, that is platelet, LDH, SGOT, SGPT, creatinine. All these parameters are sent in every 12-hour interval once you have diagnosed HELP. If there is aspartate aminotransferase level more than 2000 or LDH is more than 3000, there is a risk of mortality, increased risk of mortality. With supportive care alone, 90% of patients with HELP syndrome will have platelet count more than 1 lakh and reverse trend in liver enzymes values within 7 days after delivery. So it is seen that there is a decrease with the supportive care. That is, immediately after delivery with supportive care, these patients' values, everything comes back to normal within 7 days after delivery. Women with HELP syndrome are also at increased risk of pulmonary edema, acute respiratory distress syndrome, and renal failure. Most of them might require further treatment if they have pulmonary edema, acute respiratory syndrome, and AKI is also seen. They might even require dialysis. And some patients come back to normal after 7 days. There are patients who can even end up in chronic kidney diseases. Coming to the summary of my class, so there are these are the recommendations which are based on good and consistent scientific evidence, that is which is ACOG guidelines. So the level A evidence shows that women with any of the high risk factors for preeclampsia and those with more than 1 or moderate risk should receive a low dose of aspirin. So low dose, they say that 81 mg per day, but the dose that we get is 75 mg is the tablet. So normally we start the patients with any previous risk factors, that is moderate risk factors to high risk factors. We start them at 150 mg per day. For preeclampsia prophylaxis, initiated between 12 weeks and 28 weeks of gestation, optimally before 16 weeks of gestation, and it should be continued until delivery. In women with gestational hypertension or preeclampsia without severe features, you plan for delivery at 37 weeks of gestation. Magnesium sulfate should be used for prevention and treatment of seizures in women with gestational hypertension and preeclampsia with severe features or in eclampsia. NSAIDs medication should be continue to be used preferentially over the opioid analgesics. So you should prefer NSAIDs over opioid analgesics. Now level B evidence show that delivery is recommended when gestational hypertension or preeclampsia with severe features is diagnosed at or beyond 34 weeks of gestation after maternal stabilization or with labor or pre-labor rupture of membrane. Delivery should not be delayed for the administration of steroids in late preterm period. The expectant management of preeclampsia with severe features before 34 weeks is based on strict selection criteria. That is, expectant management is not advised when neonatal survival is not anticipated. So if the neonate is not likely to survive in preterm, then there is no point of expectant management. You should consider the maternal benefit and plan for delivery. During expectant management, delivery is recommended at any time in case there is a deterioration in maternal or fetal condition. Antihypertensive treatment should be initiated expeditiously for acute onset severe hypertension. You have to start the antihypertensive treatment. Now, the level C evidence shows that there is based on primarily or consensus and expert opinion, it is recommended that women with gestational hypertension in the absence of proteinuria are diagnosed with preeclampsia if they present with any of the following features, that is thrombocytopenia, impaired liver function, severe persistent right upper quadrant or epigastric pain, and not accounted for alternate diagnosis, renal insufficiency, pulmonary edema, or new onset headache, unresponsive to any medications, not accounted for any alternate diagnosis of visual disturbances. All these are severe features of preeclampsia. Women with gestational hypertension with severe range blood pressures should be managed with the same approach as for women with severe preeclampsia. So there is, as I said, even if they do not have any severe features, if they are not severe preeclampsia or preeclampsia, but just their gestational hypertension with severe range of blood pressure, that is 160 more than 110, they should be managed at the same way as severe preeclampsia. That is, you should do the monitoring like maternal monitoring, fetal monitoring. You have to give them magnesium sulfate, plan for delivery, and everything should be done as you treat a women with severe preeclampsia. Among women with gestational hypertension or preeclampsia without any severe features, expectant management up to 37 weeks is recommended, but with frequent fetal and maternal evaluation is recommended. So you have to keep doing fetal and maternal evaluation when you are taking them up to 37 weeks. Epidural or spinal anesthesia is considered acceptable, but the risk, if the platelets are more than 70,000, if the patient is stable with no acquired or congenital coagulopathy, if the platelet function is normal, and the patient is not on any antiplatelet or anticoagulation therapy. Thank you.
Thank you, Dr. Raisa. If you have any further questions or would like more information, please feel free to post the questions in the chat box. So, there is no questions. Please do drop your questions in the chat box. We'll try to answer them. There is a question from Dr. Saumajit Chatterjee. Any fetal teratogenicity on aspirin use?
No, aspirin is not found to be teratogenic. So it is safe to be started. Some people say you can even start them preconceptionally also. So it is safe.
Okay, there is a question from Dr. Rakesh Ranjanpati. Post-discharge medication for preeclampsia after delivery.
So if the patient has been started on labetalol or on nifedipine, you can even continue the same drug post delivery also. In case you need to change them, you can after delivery you can even give them amlodipine. You can even start them on enalapril. So normally we start them on amlodipine 5 mg OD or BD, and then in case if you need to add another drug, you can add enalapril along with it.
Yeah, sure. Thank you, doctor, for answering the question. Doctor, also you can stop sharing your screen. There is one more question from Anwarul Hakansari. MGSO4 overdose treatment, ma'am.
Calcium carbonate is given for magnesium sulfate antidote. So you give 10% 10 ml of calcium carbonate. That is the antidote for magnesium toxicity.
Dr. Mohammed Hassan is saying very nice session. Thank you, ma'am. Thank you, doctor. Thank you so much. Thank you, ma'am. Please drop your questions in the chat box. We'll try the best to answer them. Thank you, ma'am. Informative session. Thank you, Dr. Tabassum. We'll wait for 10 more minutes or 5 more minutes, doctor. We'll see if there is any questions coming up. Thank you, Dr. Rajendra Das, Dr. Sonali. Thank you. Thank you, Dr. Yogesh. Kindly please drop your questions in the chat box. Thank you, Dr. Abhishek. Thank you, Dr. Saumajit. Kindly please drop your questions in the chat box. We'll do best to answer them. There is a question from Dr. Kirti. Protein creatinine ratio is high. Can we start injection? Low molecular weight heparin.
Low molecular weight heparin is not ideally recommended for high protein creatinine ratio. Protein creatinine ratio is an indicator to show that there is features of severe features of preeclampsia.
Thank you, doctor. Doctor, actually, I have a question from one of my candidate, which she has sent me personally. There are 3 questions. Like she is asking, are there differences in how GH and PE present across trimesters?
How?
Are there differences in how GH and PE present across trimesters?
EH and P.
PE.
I didn't get the.
Okay. So what the next question is, can gestational hypertension resolve after delivery?
Gestational hypertension usually gestational hypertension is defined as hypertension which resolves after 12 weeks of delivery. So mostly if your BP comes back to normal within 12 weeks of delivery, that means you had gestational hypertension. It is not chronic hypertension.
Okay, there's one more question, doctor. When is early delivery recommended in these conditions?
Early delivery, as I said, that is in preterm delivery, you think of when there is deteriorating maternal condition, that is all those severe features which I had explained in my lecture. And if there is fetal compromise also, like a fetal growth restriction, if there is IUD, if there is abdominal Dopplers. So in these conditions, you consider early delivery.
Okay. Thank you, doctor. Thank you so much. There is one more question. I'll just... Are there new diagnostic tool or biomarkers being developed for early detection?
So as I said in my lecture, there is PIGF, which is a biochemical marker that we do on maternal serum. In NIPT also, if there is NIPT is showing high risk, so there are some features suggestive of early onset severe preeclampsia. So there are some biochemical markers, but not too much of evidence is there, but it is found to be in early onset preeclampsia, these biomarkers are found to be sensitive, more sensitive and specific.
Thank you, doctor. There's one last question from one of my group. What lifestyle modification can reduce the risk of gestational hypertension?
So as your BMI is one of the most important, if you are a gestational diabetic, or you have your blood sugars should be under control, then if your BMI is more better to bring down your body mass index, then walking, lifestyle modification like exercise, walking, then diet, then salt restriction, all these are found to be help in improve calcium intake. All this is found to improve in prevent preeclampsia.
Thank you. Thank you, doctor. There's one more question from Dr. Rakesh Ranjanpati in chat box. If eclampsia present post-delivery, can Levera be used?
Post delivery, you not, if it is eclampsia, you can give them magnesium sulfate for 24 hours. And if there is, normally we do an MRI to see if it is eclampsia, if the seizures is occurred because of eclampsia, that is, you can see features of press in the MRI. If there are other features like cerebral edema, and then better to put them on Levera. You can put them on Levera.
Sure. Thank you, doctor. Thank you so much. There is one more question from Dr. Kirti. Food items for reduce hypertension.
Restricted salt intake, food item rich in calcium. These are there's nothing like specific to reduce the hypertension, but there are, like I said, vitamin C, fish oil, all these have been studied, but nothing is found very useful. There is no evidence to show that these are good, but yeah, people have studied all these items.
Okay, sure. Thank you, doctor. Thank you, mom. Very nice lecture. If there are any questions, please do drop in our chat box. This is a question from Dr. Sushil Kumar. Labatol injection hypertension.
I think I have covered in detail about labetalol injection, how to give the dosage, and how often do you administer. Do I have to repeat it again?
You
IV
can say in short enough. What
10
is the dose you give?
20 mg you give IV. So the action is usually 1 to 2 minutes. So you can repeat the dose after 4 to 5 minutes. You can repeat the dose if the BP is not under control. So every time when you repeat, you have to double the dose. So if you have given 10 mg, your next dose should be 20 mg. If you have given 20 mg, then next dose should be 40. Like that, 40, then 80.
Thank you, doctor. Thank you so much for answering the question. Thank you, ma'am. Yeah, it's a pleasure, Dr. Z. Ahmad. Um, so I think there are no questions. Thank you all for joining us today. We hope you found this webinar informative and valuable. If you have any further questions or would like more information, please feel free to reach out to us. Additionally, we will be dropping a link in the chat box for you to fill out and submit to receive your certificates of participations, which I've already shared in the chat box. Don't forget to follow us on social media for updates on future webinars and events. Have a great evening. Vijay,
Thank you.
thank you.